So the urinary system is the system that acts as our wastewater treatment plant. You can kind of think of it like that. As we absorb things into the blood as a result of digestion, we're breaking down proteins and creating waste products called urea, ammonia, extra hormones that are not used by the body need to be excreted, and they're in the blood, but we don't have a way to get things out of the blood directly, so we have to filter plasma through the kidney, and any waste products that are dissolved in plasma enter the kidney, travel from the ureters to the bladder to be excreted as urine. So if you work in a hospital setting, we really pay close attention to the urine output of our patients. And I can tell you, I worked last night, and I only worked for 4 hours, and I had a busy little group of patients, and one thing slipped through the cracks was one of my patients had gotten out of surgery and had only urinated 75 mils in the morning and 75 mils in the afternoon. So 150 mils since like 8 a.m., and it was now 7 p.m. So that's not ideal. So I should have called the doctor on that had I noticed it, but again, you know, that's the hard part of nursing, is there's so many little factors that you're focusing on, and when your students are screaming out, "I'm in pain, you need to help me, I'm in pain," you have to take care of that. And then you have to do your assessments, and then you have to hang your antibiotics, and you have to change your fluids, and someone's on a pain pump, and you're just busy, 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 and a little thing like urine doesn't seem like on the top of your mind, but it's a big deal, because it means something's going on with those kidneys. They're not filtering the plasma and making urine like they should. So what's happening to their blood if the plasma's not being filtered? All those waste products are stuck there, right? And if we're undergoing metabolism, which we are, if you're a living person, you're constantly metabolizing. Your cells are using, you know, glucose and oxygen to give off waste products, right? Those are building up in the blood, and we need to take care of that and make sure that the kidneys are functioning and we're producing urine. So we have to always pay attention to those minor details that we think are not a big deal. So the job then, we have blood coming in from, what do we call this large vessel in the abdomen? Abdominal aorta is bringing in blood that needs to be filtered by the kidneys, so it's bringing in dirty blood via the renal artery into the kidney. And then we have these tiny little units we talked about in lab last week that receive that blood. So what is the little tuft of capillaries that's leaky that allows plasma to leave that blood, it's a bloodstream, and enter Bowman's capsule? Remember what that little tuft of, looks like a little fist of capillaries? There's a handout that I provided in Blackboard. I'm going to go to my online section. We go into our folder, lecture. This picture here is a really good thing to reference. So what do we call this tuft of capillaries right here? You might want to label it. It's not labeled on this handout. No, this tuft of capillaries is called the glomerulus. The glomerulus. And it's a leaky little fist of capillaries that can squeeze out plasma and whatever's dissolved in plasma. But anything else that's bigger than an ion or a hormone is going to stay in the glomerulus, and it's going to go right back out via the efferent arteriole. So the afferent arteriole is a small little branch that enters into this capillary network, and then the efferent arteriole is another branch that takes it out. Now this is the only capillary bed in the body that has an arteriole on both ends. In other capillary beds that we've talked about this semester, what do we call the vessel that leaves the capillary bed? Venule. Venule. Yep. But in the case of the kidneys, It's an arterial on both ends because we're not done yet. We're not done with managing this blood yet. So it's still an arterial supply. Okay, so this glomerulus then receives this filtered plasma, and then it's squeezed out by pressure. So blood pressure is what determines how much squeeze of this plasma enters into Bowman's capsule. So we'll talk about that in just a minute. Let's go back to our PowerPoint, which I always struggle where it is. Okay, so if we look at just the overall urinary system then, what the organs that make up the system, we have a pair of kidneys. We have two ureters that drain the urine that has been made from that filtered plasma, and it takes it to the bladder. And then it exits the bladder via the urethra. So the pointed, narrow end at the bottom of the bladder is called the urethra. Now in women, because of their external reproductive organs, this is a very short urethra. In males, it's a lot longer. Benefits, drawbacks. Drawbacks of a short urethra in females is that E. coli from the anal area can enter into the urethra opening very easily, and it's the #1 cause of urinary tract infections in women. And in women that are sexually active, intercourse with individuals that are touching the anal area and then moving a little too high and touching the urethra before entering the vaginal opening, that's a #1 cause of UTIs in sexually active women. So women have to really be aware of that. And if that happens, because there's not a lot of lighting, and and when we're talking about male-female intercourse, there's sometimes things don't line up correctly. So this is why we take this class and why you have me, because I'm not afraid to talk about these things, because your doctor won't. People won't ask. Some people have recurrent UTIs over and over and over again, and it's because their man is going too low and too high before he hits the right spot. So best thing a female can do is guide the guy into the right spot so that doesn't happen. And if it does happen, say, oh, stop. You got to go clean up, because I do not want a UTI for the next month and be on antibiotics in the ER at 2 in the morning on a Saturday, right? Everybody's red, including me. But we got to talk about it because it happens. Little girls, UTIs all the time, because why? They don't know how to wipe properly. And when little girls have short little arms and they're trying to wipe themselves after a bowel movement, they don't go down in front and push back, or they try to. That's because they have short little arms. You got to teach them to go in the front. And like I told my daughters, you got to push back and drop the toilet paper. Don't bring the toilet paper back forward again, because that's what they do. When they're little, 4, 5, 6, 7 years old, that's a problem. Adult women reach around the backside because their arms are long enough to go front to back. And that's how we wipe our patients, right, is we go front to back from the backside. Now, males and lazy CNAs that are cleaning up a female after a bowel movement, sometimes they're not using proper technique, right? And they're setting their patients up or their residents up for UTIs. You've got to keep that stool out of that urethral opening. It's a #1 cause. And people that have catheters that are incontinent of stool, that's a disaster, because that bacteria they have found actually climbs up the outside of that Foley catheter tubing and infects the bladder. So if a person has a catheter in for more than 3 days, the chance of a UTI is like 90%. So that's why when we have patients, we want to pull that catheter as soon as possible. And sometimes we get annoyed, right, as healthcare workers in either a nursing home or hospital, because it's like, oh great, this patient is a ceiling lift. Now they don't have a catheter, and we're giving them a Lasix where they have to pee a lot. What are we doing? We're going to spend all of our time in that room now. Why is that doctor de-seeing that catheter? Because we don't want to complicate the recovery by them having a UTI. And we also have to pay attention, because when we discharge our patients, sometimes they're showing the symptoms of a UTI from that Foley catheter right upon discharge. And that's happened to me more than once. I take a patient to the bathroom, they go pee, and all of a sudden I see cloudy, smelly urine. It's like, oh great, we can't discharge this person back to the nursing home. They'll be right back. And having readmissions within like a week of discharge is really bad for data on a hospital and how well they care for their patients. So we have to stop the discharge, put them on antibiotics, and keep them there until that UTI is resolved. So pay attention when you're dumping urine. If it's cloudy and smells bad, you need to tell the nurse right away so they can address that. Same thing with yourselves. If you're urinating and it burns, or is uncomfortable, can be a sign of a UTI, not always, but can be a sign of UTI, and it's not going to go away on its own. Some people don't have good health care, and I can't tell you, in my teaching experience, I probably had 10 students, because they know my health care background, and say, oh, I woke up this morning, I have severe pain in my lower back, and I don't know what's wrong with me, I just feel so sick. And then they go to the doctor and they have a kidney infection. And what happens if you don't treat a UTI, it starts in the bladder, then it travels up the ureters to the kidneys and causes a kidney infection. And it causes a lot of pain and discomfort in the lower back. And if you don't treat it from there, where does it go then? Bacteria. What are the kidneys hooked up to? The bloodstream, right? The renal artery and vein. So that infection can be system-wide. And if you've worked in healthcare with the elderly, you know that sometimes they get like dementia symptoms when they've had a UTI that has entered the blood. It actually causes what we call encephalopathy, which is inflammation of the brain. And they act like they have advanced Alzheimer's. They're seeing things and making nonsense. And then you treat the infection, and that's happened to me. I'd come back a couple days later after someone's been wacko on this UTI and encephalopathy, and then they cure it, and they come back, and it's a totally normal grandma that's talking sensible again and just normal little old lady because we treated the UTI. So we have to pay attention to urine. It's really important stuff. Okay, so moving on. Then we'd look at the functions of the urinary system is to filter the blood. That's number one. So if the kidneys are shot, if they're damaged from smoking and diabetes, those are the number 2 reasons that kidneys fail, is lifetime of smoking and diabetes. Those high blood sugar, lifetime of high blood sugars and not controlling blood sugars, and that's the key thing, is if you control your blood sugar and you tell your patients to pay attention to their HbA1c, which is a blood value that tells us how well they're managing their blood sugar over a couple of months. If they really pay attention to that and do well, they can prevent damage to the retina, because tiny little capillaries get damaged with high blood sugars. So the retina, tiny little capillaries. So what happens to people's vision if they don't control their blood sugar? They go blind. If they don't control their blood sugar, the glomerulus gets damaged. Their kidneys fail, and they have to undergo dialysis. The tiny capillaries of the feet and legs die and are damaged, and they lose their legs from the knees down, right? So these are all side effects of diabetes that we have to teach our patients. You have to control your blood sugars. It can be, yeah, it's a little closer to the heart, so there's not as much pressure on those capillaries as there are on the lower extremities. But their toes fall off first, right? And then they get ulcers on their legs, and then those fall off, or infect, and then we have to save the body by getting rid of the lower limb. And I had a patient just yesterday, diabetic, all clotted up. You know, all the vessels were clotted up in the neck and in the legs, and skin was in terrible shape because of poor, you know, circulation because of all this clotting up from a lifetime of bad eating. And so that person was on a low carb menu and low fat, and so he ate off of that, and then he had his family order a pizza. And they said, we're going to order a pizza. And I said, well, cauliflower crust, low fat, that would be great, you know, based on everything that's going on. We got to really watch the food. And they ignored it and came by, and they were like laughing when they came by the nurse's station, like, he wanted a pizza. And I'm like, okay. You can lead a horse to water, right? But and another thing too is, you know, just, well, I'll stop there. We got to get through this. Okay, moving on. So when we look at filtering of the blood, then what are we filtering? We're getting rid of solutes. So if we have excess sodium, is that a problem in the U.S. of getting enough sodium in our diet? Not a problem, right? Our diet sodas are full of sodium. French fries, burgers, pizza, chips, all the foods that we enjoy are pretty high in sodium. A lot of the soups that you eat, very high in sodium. So we can get rid of excesses. So there's always going to be sodium in a urine sample in most cases because it's just an excess. So anything we bring in that's excess is going to end up in the urine because these are dissolved in the plasma. Solutes is just a term for anything that is dissolved in plasma. pH. What ions in our plasma control pH? What are 2 common ones we've talked about? We won't go a lot into acid-base. That's for advanced A&P. But what are 2 common solutes that we've talked about this semester that influence pH. Bicarbonate ion, which is a result of carbon dioxide metabolism, or in the red blood cell it's made there. But bicarbonate ion raises pH. And what's the other ion that lowers pH? And pH is a measure of this ion. Hydrogen ion. Yeah, so hydrogen ion and bicarbonate ion are managed by the kidneys. Blood cell synthesis. Do you remember what hormone is secreted by the kidneys when the oxygen levels get low, like in people with bad lungs, or people that live in high altitudes, or people that are training in the mountains of Denver? What is the name of that hormone that's used for blood doping illegally in some athletes, like Lance Armstrong? Remember what that was called? We talked about it back in the skeletal system, I think. Starts with an E. EPO, erythropoietin. Do you remember the name of that hormone, erythropoietin? Stimulates the bone marrow to increase red blood cell production. So that's where blood cell synthesis comes from. The kidneys secrete that hormone, erythropoietin. It's right here on the slide. So right here, make sure you highlight that so you don't forget about that. And synthesizing vitamin D. Remember, we need vitamin D for what? Lots of things. What's the main function that we talked about? Yeah, calcium absorption. So all of our milk that we drink has been vitamin D fortified to help us absorb that calcium in the milk. But also vitamin D is important for immune function. It's helpful for mood control. We find that, we have that seasonal affective disorder or seasonal depression when people aren't out in the sun. They're not producing enough vitamin D, and that's linked to depression. So people get a little blue in the winter months. So it's important that we get vitamin D. And if you don't get a lot of vitamin D in your diet, which 80% of Americans don't, they recommend supplementing with about 2,000, whatever the unit is, I forget, of vitamin D. Is it milligrams maybe, or MIU or something like that? I forget. But 2,000 is what they recommend people have now. And we're not really good at testing for vitamin D. But every cell in the body has receptors for vitamin D. So there's things that we don't even know that vitamin D does for our bodies. So it's important that we get enough of that. We do know people with low vitamin D have depression, anxiety, poor immune function, and poor calcium absorption. So who can't benefit from some vitamin D for those reasons, right? Okay, so the nephron, it's the structural and functional unit of the kidney. That is a key definition to memorize. When you think of the kidney, its job is to filter urine. Well, what is filtering the urine? It's the nephron. And the parts of the nephron are Bowman's capsule, which is the beginning of the nephron. That's what receives the filtered plasma from the glomerulus. Then we have the proximal convoluted tubule. Convoluted just means it kind of goes in all different directions. Then we have the loop of Henle. It looks like a little paper clip, a hairpin. So this loop of Henle dips down deep into the medulla. And then we have the distal convoluted tubule. So the proximal and distal convoluted tubule and Bowman's capsule are out here in the cortex. See the lighter color in the background? So this is in the outer margin of our kidneys. That's where the blood supply comes in. So there's exchange between these parts. And then there is another little special blood supply around the loop of Henle in some of our special nephrons that are in charge of concentrating urine. We'll talk about that. And then it hooks up to the collecting duct. And the collecting duct is kind of like the sewer pipe in a neighborhood that serves several different houses. So it's not part of the nephron. It has special connections here you can see that are for other nephrons. So the end of the nephron is the distal convoluted tubule. So if we look at what happens in each of these sections here, I'll make this a little bigger. So we have the glomerulus, which is this leaky tuft of capillaries under pressure from the blood pressure of the body. So the higher the blood pressure, the more filtration. If you have really high blood pressure, that damages the glomerulus. Again, it's too much pressure on that delicate capillary bed, and the little holes in the glomerulus become larger, and then we start to see blood leaking out and proteins leaking out. When there's damage to that glomerulus, the solid, bigger things in the plasma that are supposed to stay in the plasma end up leaking into the kidney, and then we find them in the urine. So cloudy urine, pink urine, protein in the urine, all bad things, a sign of damage to the glomerulus, because those big things are supposed to stay in the glomerulus and not leak out and enter the nephron. So we can see that there's a couple of different processes that occur in the nephron. Right here in the proximal convoluted tubule, we have a lot of things leaving the nephron and going back to the blood. If we look at our picture here that puts the blood and the nephron together, so the glomerulus is a blood vessel, right? So if something enters the proximal convoluted tubule and goes right back to the blood, it's going into these vessels, which are called peritubular capillaries. And if you look at your handout, you can see they're labeled. Maybe you want to hide, if you have a black and white handout, maybe color these red so you can see that they're blood vessels. They're not part of the nephron. So those things will go back to the blood. So what is something that would be filtered out of the glomerulus non-selectively that we want to say, no, 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 go back to the blood. We don't want you to enter the bladder and be urinated away? What is something that the body always keeps, and if we have excess, it is stored as fat? What's the #1 molecule for metabolism? Glucose, yeah. So 100% of the glucose that is filtered out of the glomerulus and enters Bowman's capsule, when it gets to the proximal convoluted tubule, it is actively transported back to the blood, back to these peritubular capillaries. And if we follow the peritubular capillaries, we'll see it enters a venule, goes back to a vein, goes back to the inferior vena cava, and we're back in business again. And that can be used and stored or whatever. So we should never see glucose entering the nephron and going into the bladder. Glucose. They will. We'll talk about that. Yeah. That's abnormal. That's in a normal urine sample, we should never see glucose in the urine. And then another thing that is really important that the body does not want to waste are amino acids. So when we've digested our proteins and created amino acids in the blood, those are filtered out. Those are small enough to leave the glomerulus and enter proximal convoluted tubule. We do not want those to enter the nephron any further, so those get reabsorbed back to the blood. So 100% of the glucose, 100% of the amino acids go back to the blood right away in the proximal convoluted tubule. So on the handout that has this picture, if you turn it over to the back side, look at #1. #1 says, the non-selective movement of fluid and solutes from the glomerulus to Bowman's capsule is called, what do we call the movement of things from glomerulus to Bowman's capsule? Starts with an F. Filtration. Filtration. So I'm looking at the back side of the handout that has this picture, and it's posted in Blackboard for you to print off and look at. So we call that filtration. So right here, this movement, I'm sorry, here is filtration. It's not shown on that. So what did we say should not be filtered? What should stay in the blood supply and never enter the nephron? No, that's what gets filtered back. That leaves the glomerulus. What is stuck here because they're too large? The only substances that are not filtered, so that means not leaving the glomerulus and entering the Bowman's capsule. What are the big things in our blood that should not be able to squeeze out of the glomerulus? Blood cells. Blood cells. So white blood cells, red blood cells, platelets. And what molecules do we say are really big that should not leak out? Albumin is an example. What is albumin? What molecule is it, Taylor? A protein, yeah. So large proteins like albumin, red blood cells, white blood cells, platelets, those are the only substances that are not filtered out of the glomerulus due to their size, their large size. Because they're too big, they're not going to be filtered out. They're going to stay in the plasma or stay in the glomerulus and go back to the blood. So if we see them in the urine sample, we know there's damage to the glomerulus. It's too leaky. There's something called glomerular nephritis, which is a cause of some of these things being in the urine. Okay, so when solutes are actively transported from the nephron back to the blood, so when I look at this going from the nephron back to the blood, this process right here of all these things that leave the nephron that were filtered out, and the body's like, nope, back to the blood you guys go. We don't want to lose these things in the urine. That's called tubular reabsorption. Tubular reabsorption. And most of this occurs in what part? What is this called here? Yep, proximal convoluted tubule. Proximal means it's right next to Bowman's capsule. It's connected to it. Proximal, right, close proximity. Distal means distance, further away. So that's why this is the distal convoluted tubule. So this is tubular reabsorption. Most of that occurs in the proximal convoluted tubule. And the way I would write this for speed is PCT. Just abbreviate it, PCT, proximal convoluted tubule. And so now, Bridget, you can answer this one. 100% of what leaves this and enters, you mentioned it earlier. Very good. Glucose and amino acids. So 100% of the filtered glucose and amino acids that's in this proximal convoluted tubule is sent right back to the blood. We do not want to see that in the urine. So we actively transport that. There's special transporters that'll move that back to the blood. I'll finish up in just a minute. Now, Nate, you mentioned why does, it enter, or in diabetics, that's not the case, right? Well, there's a number of proteins that are constantly cycling glucose, but there's what's called a transport maximum. So if there's so much glucose because of high blood sugar entering into that nephron, those transporters can't keep up, and glucose does spill into the urine. So the transport maximum is exceeded in those people with diabetes. Okay, so we will pick up next time in the next video with the rest of the kidney and its functions.